The broadcast is now starting. All attendees are in listen-only mode.
Hi everyone, thank you so much for joining us. We're going to get started in about 2 minutes. I'm going to give a few minutes for latecomers to join in the conference, and we'll get started in about 2 minutes. Thanks. Hi everyone. Thank you so much for joining us for this webinar today. My name is Tanya Ladhicht, and I lead CureSearch's research and educational programs. CureSearch is so happy to be able to provide these webinars for school personnel and families facing a childhood cancer diagnosis. Today's webinar is the second of a two-part series. It follows from a webinar earlier in October that provided guidance for school personnel and child life specialists and families about how to support a child with cancer soon after diagnosis. Today's webinar focuses on reentry and reintegration into the school environment. Ending treatment can be a time of great transition for children and their families. Patients have endured a lot, usually intensive chemotherapy, radiation, hospital admissions, isolations from their friends, and academic disruption. This webinar will focus on strategies to ease children back to school, with special attention given to social and emotional aspects, as well as academic considerations, legal issues, cognitive side effects that can affect learning, and helping school staff and families work together to support these children. Before we get started, I want to remind you that we will have about 20 minutes for questions at the end of the webinar. If you have any questions during the webinar, please type them into the questions or the chat window, and I will collect them to ask the speakers after they've finished their presentations. I also want to let you know that we will be recording today's session, and it will be available on CureSearch's website later this week. I'll also be sending an email with information about the recording in a few days. Now, without further ado, I want to introduce today's speakers, Mindy Szelap and Katie Devine. Mindy is a clinical social worker in pediatric specialties in San Francisco. She's worked with pediatric oncology patients and children with chronic and life-threatening illnesses in Bay Area children's hospitals, summer camps, and nonprofit agencies for almost 25 years. She writes, speaks, and teaches extensively on topics related to helping children and families better cope and adjust to chronic and critical illness. She also has a private pediatric psychotherapy practice in Oakland, California. And full disclosure, I'm also a cancer survivor, and Mindy was my psychologist when I was in treatment, and she's really wonderful. Katie Devine is a pediatric psychologist who works with children, adolescents, and young adults with cancer. Her research focuses on enhancing the psychosocial functioning of childhood cancer patients and survivors. Her recent work involved the development and evaluation of a school-based peer leader intervention to improve the social functioning of children surviving brain tumors. Along with her research work, Katie also has a personal connection to childhood cancer. She is the sister of a long-term survivor of childhood osteosarcoma, which is a bone cancer. So thank you so much to both of you for being here today. I also want to say thanks to Ronald McDonald House Charities, which provided the funding for this webinar series. So now I'm going to turn it over to Mindy, who's going to start us off.
Thanks so much, Tanya. So let's get right to it. Many of you were here to listen to Dr. Amelon and Kathy's presentation, and we're just going to expand on that now and look at what it's like for these children once they are either finishing treatment or kind of ratcheting down to treatment that will allow them to begin to attend school again. Some children are still on treatment when they go back to school. So here's an overview of what we're going to be discussing today. We're going to review very briefly the treatment course and then look at a framework for reintegration, talk about some classroom presentations for students, explore the developmental considerations of different, both the patient who's re-entering as well as the students in the classroom, talk about some educational and legal issues. We'll go over some case examples, which will also include a sample classroom presentation, and then we're going to talk a little bit about what happens when children relapse or go into palliative care in the classroom, and at the end we'll offer you some resources. So when these children return to the classroom, they come with a very full backpack of experiences. These children have experienced perhaps lengthy hospitalizations, periods of isolation from peers, chemotherapy with the side effects that go along with it, and a great deal of focus on keeping them safe from infection during their treatment. Some of the physical symptoms that may be obvious upon their return are hair loss, mouth sores. Some children may still have some significant GI issues. They've experienced nausea and vomiting in the past. They may have some bathroom issues, and fatigue and anemia are also common. The emotional issues that they bring back with them, perhaps symptoms of anxiety and depression, a feeling of self-consciousness, lower self-esteem. Many of these children have a lot of social anxiety. They've been away from other children for long periods of time and have mostly been interacting with adults and adult health care providers. This also creates a feeling of dependency, of needing to check things out with adults frequently, and self-doubt about their own sort of agency in the world. There might be a feeling of hypervigilance, as when children are in the hospital there is a lot of focus on signs and symptoms of getting sick, of infection, real awareness of what it felt like them when they were being diagnosed, and they may be very hypervigilant about their bodies or about cleanliness or infection precaution. There may be fears of contamination because we've spent so much time drilling it into them to stay out of places where they could become sick when they're immunocompromised. And again, a real focus on the physicality of themselves and the world and their bodies and what they're experiencing. Things have also changed socially for these families. There's a new normal. There may be a change in family roles and hierarchies. One parent may have had to stop working, or another parent has needed to work a lot more. Perhaps both parents, or if it's a single parent family, have had to leave their jobs. Other members of the family, perhaps young siblings, have had to take on more roles and responsibilities. This can cause a great deal of financial upheaval. There are social shifts, and many parents will tell me that it just doesn't feel the same for them interacting with other parents who are worried about things such as carpool schedules or soccer practice or sort of the neighborhood gossip or school goings on, when they're worried about the life and survival of their child, and it can feel very alienating for families during this period of time. And so everyone in the family, not just the patient, are trying to reintegrate back into day-to-day life. These children may have also had very different educational experiences. They may have had a home-based teacher or been involved in the hospital school. And that, again, is a big shift for them. So what do they need? They need encouragement to reintegrate with their peers and to join the world of children again. They need to be supported around mastery in the classroom, and they need reassurance about pathways to get to help if they were to need it, to make that very simple and straightforward for them. A smooth transition. This is all starts with a planning meeting, which really lays the groundwork, and then moving to preparing the student to return to the classroom, as well as the sibling preparing for their brother or sister to return to their school, and then preparing the classroom that the child will return to, as well as the siblings' classroom, and then a concrete plan for checking in and reassessing as things evolve. So the first part is the planning meeting, and the very important people involved in this meeting are the child's teacher and the siblings' teacher, a school nurse, the school counselor or social worker, the principal, a special education representative, and even if the child at the time doesn't have any special educational needs, there are late effects that can appear later, and it's really nice to have those people involved from the very beginning. The office secretary or the child's point of first contact when they do walk into the office and need help plays a very important role as well and should be in that meeting. It's also the person answering the phone when the parents call and really should be a point of contact for a lot of different information. The parent should be in this meeting. They are the experts. And then, if possible, a hospital liaison. And some hospitals are able to provide that as well. So as you begin to lay the groundwork in this meeting, it's important to recognize that the parents are the experts. They have been with this child every step of the way and have a very refined knowledge and sensibility about what their child has been through. It's important to discuss the dissemination of information and what is comfortable for that family in terms of what people should know and who should know and how that information should be disseminated. And that can look very different from a kindergartner through a junior in high school. Getting the parents' description of what the medical course looked like and what they believe the child's current needs are, the parents' assessment of what the child's emotional state is from the parent's point of view. And again, it's important to recognize that what a parent sees and what a child displays at school might be different. But to get where the parent's coming from. The parent's concerns and expectations from the school, it's very important in the beginning to understand what the parent's expectations are and to, as a school, discern if that falls into your purview, and if not, to help sort of define where the roles are so that later on there's not misunderstandings and frustration. And also a big part of this conversation along with the parents is discussion of the siblings' needs, both to hear from the parents what they think the siblings' needs are, as well as to let the parents know that the siblings' needs are being brought into very high consideration in this transition. So the school is a resource. It's the time to review the educational course during treatment and any educational testing that's taken place, enact a plan to deal with the special medical needs the child has, if the child has medications they're coming back with, if the child has a central venous catheter, and to really review all of those things that need to be taken care of on the school site. Come up with a plan for the accommodations, a written safety plan with all the emergency numbers, and then identifying roles, and as Kathy spoke, a case manager, someone who's in charge of the plan at the school, a go-to person, and then a plan for communication, reassessment, and review. So in terms of the communication tips, communication is really the key in a successful transition and moving forward with these children. Again, selecting a case manager will be in charge of the plan, and using many forms of communication: phone calls, conference calls, email, written notes. A two-way journal is a wonderful way to involve the patient or the child who's transitioning back in the process, where the teacher can write in the journal, the parents can write in the journal, and the child can write in the journal. And it's a good way to check and recheck if people are on the same page. much. And then to plan for regular conferences to follow through, be it every 6 weeks or during crucial points in transition in the child's therapy or in the school year. It's important to have that in writing of when those planned conferences will take place. Even if one occurs sooner, it's important to have something in writing about that. So jumping back in, returning to school is so important for these kids. It's a return to their job, it's a return to routine. School is a place where children fulfill their potential. It's a place for them to feel like they're moving forward in life and to feel normal. And above all, it gives them hope. So preparing and supporting the student. So these children, as they turn back to the school setting, the normal place where children spend their days, they're transitioning from medical personnel, doctors and nurses, being their go-to adults to the teacher being their go-to adult outside of the family, which is really the normal way that children function in the world. So a teacher can really meet a lot of a child's emotional needs in returning to school by taking the time to sit with them, discuss their hopes and fears, come up with a plan for accommodation and how that's going to be operationalized. Help the child walk through a plan for getting help, especially if the child's younger, actually walking them through the steps and helping them practice who to go to and how to get the help they need. Identifying a safe person. Now, in the younger grades, that's going to be adults. And perhaps in the older grades, along with adults, you may also identify safe peers that that child can go to if they need help, especially in adolescence when young people are much more apt to go to their peers to confide or to get assistance or opinions. A teacher can really assist a child in coping in the classroom and to decide with whom and what to share and what to keep private. So moving on to more specific examples, for the elementary school child, their developmental task is, in Ericksonian terms, is industry versus inferiority. This is the age in which children need to master things, reading and writing and social relationships. This is how they grow and develop, and the school is the perfect place for children to do this, and for their psychological well-being, they need to be able to do these things. And as I talk about this, I'm talking about both the child who's returning to the classroom as well as the children in the classroom. And when we're teaching them about this child who's returning's journey, they can really take on learning about that, and that contributes to their sense of industry and mastery. So in the younger grades, grades K through 3, these little guys are just so curious, and they are concrete thinkers, as you all know. Things they worry about is, can they catch cancer? Did the child do something bad and that's why they got cancer? Is the child changed from their cancer or their treatment? Are they a different person? And they worry, will I get cancer? So these are the sort of concrete ways to address their information needs. A concrete description of cancer cells is the little tiny things that make up all parts of the body. And you can give a brief description of what those cells do. That some cells come together and they form the heart, and other some cells come together and they form the lungs or the blood. And you can talk about how some of these cells get confused, some of these cells that are unhealthy, and they start growing too much. And it doesn't leave room for those healthy cells that the body needs to grow to be healthy and do their job. So the children need medicine like chemo to get rid of these confused and unhealthy cells so the healthy cells can grow. You can give a brief description of the medicine children get, which is called chemotherapy, and that they go to the hospital, and it's the medicine that can make them lose their hair or feel more tired or get tummy aches. And it's important when they're taking this medicine to stay away from other people who are sick. It's also very important to let these children know that you cannot catch cancer. And it's sort of like catching a broken leg, and children will know that that's a very silly thing and can really identify with that. Their emotional needs. at this age. The child didn't do anything to get cancer. It's just something that happened, and it's very rare. And the child's the same child they were before. If they liked chocolate ice cream before they got sick, they probably still like chocolate ice cream now. It's just exactly the same kid. These children are just beginning to understand empathy in a different way, and you can make it very concrete for them by talking about, asking if any of them have ever been to the hospital, and what was that like, and does anyone know anyone who's had cancer? And this may be when children start talking about grandparents who've had cancer and have died, and you can talk about at that point that children are different. They're young and they're growing and they're very strong, and all the doctors are very good at making children who have cancer get better, and they're working very hard to make sure Johnny gets better from this. And then a discussion about how to be a good friend, which little guys have lots of good ideas about, as I'm sure you all know. Older elementary school, you can open up the conversation by discussions of what other children have had for their medical experiences, and by older elementary, most children have had some interface or known someone who's gone to the hospital. You can talk about how cancer cells are cells that divide very quickly, unhealthy cells, and they crowd out healthy cells, and then open the conversation of what would happen if these cells kept crowding out the healthy cells. And again, that will open the conversation of that a child would die if there were too many unhealthy cells. And you can, again, talk similarly about how children are stronger and more resilient, and we fully expect that child to get better. You can discuss, again, how chemotherapy is medication and the side effects. And they can understand on a slightly more mature level that you can't catch cancer like you can catch a cold or the flu or a virus, and that can also be turned into a mini science lesson. And at this age, they're also becoming aware of probability versus possibility, and being very concrete about how, of course, there's a possibility, but it is not probable that they will get cancer. And they really like to master this sort of information at this age. Emotional issues at this age, again, a more developed sense of empathy is coming in. Being able to say to them, how would you feel in a similar situation, and have them talk about their fears and their emotions and their feelings. Asking if anyone's been through something similar and what it was like for them. And what would they want their friends to know if they were going through something like this, and what would they want? And this is a great time, this pre-adolescence, a little bit older than the little guys, to make the patient the expert. And the patient can be really great at helping design what they want their classmates to know if you talk to them before. This also really gives the patient a sense of expertise and mastery as well, if that's the right thing for that patient. Adolescence, it gets a little bit trickier in adolescence, as you can all imagine. The developmental task in adolescence is identity versus role confusion. This is the age where kids are beginning to try on different hats about who they are. And these children who are taken out of the classroom at this age are taking on the role of being a patient, and it's really important that they're able to go back to school and begin to take on normal adolescent roles. So it's even more important that they're able to be reintegrated with their peers at this point. There's a time where there's a greater need for individuation from parents, and they've had to be very dependent on their parents going through this terrible illness. So it's really a time to encourage them in a safe way to begin to rejoin their peers and start experimenting and exploring a greater independence. Again, peer relationships are of the highest value. Fitting in, which can be challenging when you've lost your hair and you're fatigued and not feeling well. And privacy is of the highest value at this age. So it's so important that the adolescent really drive the dissemination of information. So the teen may choose to disclose to just a few close friends, and that's okay. It's really nice when those close friends can be brought into the planning process as well, so they have a sense of ownership and fidelity to that child who is, or that adolescent who's returning to school. You can identify some adult champions in the school, and it may not be the obvious people. The student may have a connection with the teacher from the year before they got sick, or someone else in the classroom, but to have some adults identified that the adolescent feels comfortable going to when they need help or support. Accommodation plans, in addition to other ones we talked to, ones that can be a little more sensitive, may include access to private bathrooms, permission to wear a hat or headscarf. I know that's forbidden in a lot of schools these days, but it's really important these kids be allowed to do that. And then arrangements with office personnel regarding safe places for them to rest. And it may not be safe for some of these kids to go into the nurse's office, as they may still have some issues with their immune systems, and it might not be good to be around children who are coming with fevers or flu or other communicable diseases. A classroom presentation, although it is rare that a teenager would want a classroom presentation because of their usual high need for privacy, but it happens, can be done usually by a science teacher. I know that at the hospitals I've worked at, there's always been doctors and nurses who are very happy to speak with science teachers about ways that they can cater a specific science lesson based on that child's diagnosis. You can talk in a much more refined way about how cancer cells crowd out healthy cells, and without treatment the patient would die, and that chemo attacks both healthy and cancer cells. So patients experience side effects, and you can talk about hair loss and nausea and vomiting, tummy aches, mouth sores, fatigue. Emotional aspects in a classroom presentation. The developmental task of teenagers of learning social relationships can really come into play here, and they have a much more refined sense of empathy that you can tap into, and with the right support they can really do a beautiful job just talking about how they would want to be treated and what would help you if you were in a similar situation. They have a great ability, sort of an emerging ability to take another's perspective at this point. Okay, I'm going to now turn it over to Katie.
Thank you, Mindy. I'm going to talk a little bit about how cancer treatment affects learning and education. Some issues are going to occur while the child is still on treatment, but others might occur years or months or even years after the treatment has ended, and those we typically refer to as late effects. The issues tend to occur in three main areas of functioning: physical, cognitive, and social. And families, as Mindy said, families are really the experts, and they're going to be a great resource about what to look out for. And of course the medical staff also can be available to give insights to this as well. And it's important to know that not all children will be affected, but I'll cover the most common issues here. In terms of physical effects, fatigue is very common while undergoing chemotherapy or radiation treatment and may persist even after the treatment ends. Less common physical effects that can influence learning and education include seizures, problems with eyesight or hearing, and if an amputation has occurred, a child may have a prosthesis or may require a wheelchair to ambulate around the school. In terms of cognitive effects, attention and concentration is very frequently affected. And usually this happens without any hyperactivity. Teachers may be used to seeing attention problems in conjunction with hyperactivity in school, but this typically for cancer survivors, it happens without hyperactivity. And it might be seen as kids seeming disinterested or just not paying attention. Processing speed is typically affected, as well as memory. Executive functioning, which includes skills such as planning, organizing, strategizing, and managing time, as well as visual perceptual skills. In terms of the social relationship, most survivors do experience a prolonged absence from school during treatment, And the majority of cancer survivors will not experience major social problems when they return to school, and they won't see many changes in their friendships. But there are a subset of kids who are going to experience some changes in their friendships, and in particular, children surviving brain tumors and those who experience some of the physical and cognitive changes that we've described are more vulnerable to experiencing a reduction in friendships or even having teasing or isolation from their healthy peers. So as I said, not all children will experience late effects. And there's a whole body of literature that has found certain factors to put kids at greater risk for experiencing these. And these factors include cancer treatment that involves the central nervous system, the brain or spinal cord, being diagnosed at a very young age, experiencing radiation to your head or your total body, which includes your head, and certain types of cancers because of their location and the types of treatments that to cure them. In particular, children with brain tumors or tumors of the central nervous system, children with acute lymphoblastic leukemia or ALL, which is the most common childhood cancer. Although contemporary therapy has really reduced the neurocognitive impact of this treatment, many children treated for ALL do experience some neurocognitive declines, and girls or very young children are particularly vulnerable. And then tumors in particular locations, like tumors in the eye, could impact eyesight. Now I'd like to discuss the federal laws that are relevant for obtaining services for children with cancer. And school personnel are probably very familiar with these laws and their purposes, so I'm just going to briefly go over their purposes here. And really the goal of all three of these laws in particular are to help protect children with disabilities, which can include illnesses such as cancer. And really the ones that you're likely to see the most or will focus on are IDEA and education law and the Section 504 civil rights law. So the American with Disabilities Act protects against discrimination in employment and public accommodations. IDEA, or Individuals with Disabilities Education Act, is an education law protecting students. And the Rehabilitation Act of 1973, the Section 504, is particularly applicable for providing accommodations for students. Under IDEA, a child with a disability is guaranteed a free and appropriate education. And for children with cancer, they typically qualify under the category Other Health Impairment. An evaluation is required to determine services, and the product here is an individualized education plan for the student. And school personnel, I'm sure, are very familiar with IEPs, but just briefly, their purpose is to establish measurable annual goals for the child and to define the services that the school or the school district will provide. And who is involved in these meetings? The parents are involved, as well as particular school personnel, typically the regular education teacher, the special education teacher, the school psychologist, or someone who can interpret the results of the assessment of the child, as well as the principal or another school representative who's familiar with the services that the school can and is required to provide. The contents of the IEP have to contain certain things. First, there has to be a baseline level of where the child is in terms of their current academic achievement and performance. The annual goals must be specified, and how the child will be measured, or how their progress will be measured for those goals. Any particular special education services that will be offered, as well as any modifications to the program. The extent of participation in regular classroom activities, and individual accommodations. And for children with cancer, most children will remain in the regular classroom with accommodations and possibly some special education services. And the IEP must also detail when these services will start and how often the child will receive them and where the child will receive them. Section 504 defines a disability as any condition, including illnesses such as cancer, that substantially limit one or more major life activities, such as learning, walking, or climbing stairs. So typically, children with cancer will experience some some limitations in one of those areas. And the accommodations are intended to provide a level playing field for students to really overcome those functional limitations and have the opportunity to perform at the same level as their peers. Here's a list of accommodations that are commonly helpful for children with cancer. One is an extra set of books for home and for school, so the child does not have to carry books back and forth. It can be helpful to give the child a computer or an audio recorder or have a personal note taker to reduce the writing requirements for the child. And this also helps to account for delays in processing speed or attention and memory. To address fatigue and other physical needs, it can be important to allow the child to have access to drinks and snacks throughout the day, have a bathroom or a pass to the nurse's office so they can go as often as needed or even go to take a rest during the day. It can be really helpful to allow the student to leave class 5 minutes early to travel to the next class. So this will allow the student to walk between classes when the halls are empty and reduce bumping into other students. And here it also can be very helpful to have another student accompany the child with cancer to help physically carry anything they need to carry, but also to provide some emotional support and just be a friend during that time. There should be alternatives to gym class or physical education. For children who do lose their hair or have physical appearance changes, it would be nice to be allowed to wear a hat or a scarf during the day. It can be very helpful to have a shortened day or a modified schedule to account for the physical demands of being back in school. If the school is 2 floors, it can be very helpful to have an extra locker, so one on each floor, so the child doesn't have to carry things up and down stairs. And for those children those older adolescents who are driving themselves to school, it can be nice to have a parking pass close to school so they don't have to walk too far to get into the building. As was discussed in part 1 of this webinar series, a home tutor can be particularly helpful during the acute phase of treatment when students are missing a lot of school, and can be helpful even when they return back to the classroom to catch up. It can be really helpful for students to have extra time for assignments and tests, especially for those who are experiencing problems with attention and concentration and processing speed. Teachers should consider modifying tests to reduce the writing burden. It can give oral tests or some limited multiple choice questions. And really think about modifying the workload. What is the essential work that the child needs to complete to demonstrate mastery of the concepts that you're trying to teach? Here the focus is really on the quality of the child's work rather than the quantity. It can be very helpful to adjust the attendance policy given the frequent absences that children often have, and extending the school year will give time to allow the child to complete the work to stay at grade level, which can be very important to children undergoing treatment. There are also a few special considerations to think about. Transitioning to a new school can be particularly challenging, especially with social issues. And some particularly challenging transitions for all kids, not just children who experience cancer, are the transitions from elementary to middle school and the transition from middle to high school. And undergoing cancer treatment during this time can really complicate these normal developmental challenges. And so you might want to give extra attention to the needs of the child returning to a new school during those transition points. Educational issues also may not be evident in elementary school when children can also often overcome some of the difficulties that they're experiencing. But you might not see the problems emerge until the demands of the work get greater as children enter middle school and high school, where really the workload demand goes up significantly, as well as the need for being very organized, having good time management skills, and using more abstract critical thinking and reasoning skills. So some of the late effects the cognitive late effects that we're seeing may not become apparent until these times, even though treatment may have occurred years earlier. Often children might be able to accommodate for some of those deficits when the workload is not too demanding, but as it gets more demanding, you start to see these issues emerge. Now we'd like to switch gears a little bit and try to put together all this information into a couple of case presentations. And I'm going to start with a little girl that we'll call Maya. She's an 8-year-old girl in the 3rd grade who was diagnosed about 6 months ago with ALL, which is one of the most common childhood cancers. And here we're going to talk about the time when she was returning to school following the completion of her 6 months of intensive chemotherapy. So her cancer is really in remission at this point, but she continues to receive maintenance chemotherapy for a period of time to really reduce the likelihood of any of her cancer coming back. She lives at home with her mother and father and her 10-year-old brother who attends the same school as Maya. So some things to consider. Who do we want to be in this child's planning meeting? Here's important to include all of the key players. So her teacher, although she did not previously have any special education needs, be important to include the special education teacher, the school social worker, her parents, the school's secretary as a point of contact for her and her parents, the principal, and because she has a sibling in the school, it would be important to include his teacher and the person who's identified as the school liaison or the person who will be the go-between with the family and the school. For Maya, her parents have told the school that some of the ongoing considerations for her are fatigue. She's going to be continuing to be on medication. She has already demonstrated some difficulties with attention and concentration. She has ongoing GI issues. And she has a central venous catheter still inserted in her chest, so she'll be continuing to have that when she's back in school. So some accommodations that we mentioned that are relevant here, because she's had a lot of absence already and continues to experience some fatigue and everything, it's important to have adjustment to the attendance policy so she can try to maintain her grade level. Her fatigue makes it difficult for her to stay on task during the day, and so having a shortened day or getting frequent breaks will be helpful. Having morning and afternoon snack breaks as well as water to help keep up her energy and her nutrition. And given her GI issues, it's important to allow her to go to the bathroom whenever needed. It's helpful to have the 2 sets of books, one for home and school, and she does need to have a modified physical education plan at this time. Other educational accommodations, given her attention and concentration difficulties, it would be helpful to have extended time to complete her classwork and tests. Again, given her history of absence and wanting to stay on track, help focus on the quality of the work. What are the essential tasks she needs to show mastery of at this grade level, rather than having to do every single assignment. When she is distracted or intention is very important, small group instruction can be helpful to keep her on task. And having flexibility with the homebound teacher, allowing for attendance at school as much as possible. A sample classroom presentation for her can be given if someone is available from the hospital. It would be nice to have someone from the hospital come to give a talk to the classroom. If that's not available in Maya's area, a school staff member can take this role, and typically it might be Maya's teacher or the nurse. And this person can talk with the hospital staff ahead of time to get all the relevant information that they need about leukemia before presenting it to the children. And most likely we would not have Maya here at this initial classroom presentation, giving the children more freedom to ask any question that they might have, and making it more likely that you can address concerns that maybe they wouldn't bring up in front of Maya. So it's important to start with what is ALL, and here it's helpful to use the correct terminology, but also use concrete language that the children can understand. So most of the kids will not have ever heard of acute lymphoblastic leukemia, but it is important to explain what it is. Something very simple like ALL is a cancer of the blood. And you might ask kids, what does the blood do? And they might be able to tell you a little, very in simple languages, what the blood does, and that it's made up of different types of cells, like red and white blood cells. And the kids might even know that white blood cells help keep us healthy by fighting off illness. And it's important to give them a simple explanation for how what cancer cells do. And as Mindy mentioned before, something like some cells get confused and start growing too much. Can be simple enough to explain that what cancer is doing in the body. It can be helpful for kids to have a diagram or a chart of where the cancer is. Now for leukemia, it's in the blood, so it's all over the body. But if it's a particular type of tumor in a particular location, you could show children on a diagram or on a picture where it is. And most kids are curious about that. Then it's important to have a discussion about the frequently asked questions that children have. So kids often want to know, can you catch cancer? And it's very important to be clear that no, you cannot catch cancer. Mindy's example of, like, you can't catch a broken leg is a real easy one that children can relate to and really understand. You can also say it's not like a cold that you can catch. Children will often want to know, why did Maya get cancer? Was she bad? And of course, no, this is, no one knows why Maya got cancer. It's nothing that she did. There's nothing that kids can do to get cancer. When you're talking also about catching cancer, it can be helpful to give kids examples of things that they can still do with Maya. So you can't catch cancer, so you can still sit close to Maya. You can give her high fives or hugs, things that are okay to do. It's important to let kids know that. How do you get rid of cancer? Here you could say something like, doctors give Maya a special kind of medication called chemotherapy to get rid of the cancer. And it might be helpful to tell them a little bit about what the medication does also and some of its side effects. So this medication can make your hair fall out and make you feel tired. Simple language that kids can understand and kids can relate to feeling tired, things like that. Will Maya die? It's important to address this concern because a lot of kids, even if it's not directly asked, they probably are wondering about it. And so here it's really important to say that the doctors are doing everything that they can to cure or fix Maya's cancer. And in Maya's case, she's actually coming back after her intensive chemotherapy is completed. So really, here you can say that she already finished medications that got rid of her cancer, but she still has to take some medications for a while. And here for Maya, she actually did lose her hair, so it's good to let the kids know this. The medication made her lose her hair, but it's starting to grow back now. She also gets tired a little more easily. She can't play sports in gym class like she used to right now while she's taking the medication, but she's still the same person that you know her as. And it's really important to emphasize to kids that she's still the same kid coming back to them. And it can be really helpful to have a discussion about how can you be a good friend to Maya, and kids can have a lot of really great ideas about this. And as a teacher, as a principal in the school, when you see kids doing things that show that they are being a good friend to Maya, it's important to reinforce that and give the kids some praise for doing helpful things. And this helps the kids feel good about themselves, and it helps, I think, it would help Maya too feel good about these positive interactions. And in this classroom presentation, because Maya does have a sibling in the school, it might be important to include the siblings classroom. And I would say before doing that, it's helpful to ask the parent their thoughts about it. The parent knows the sibling the best and really will know how the sibling is reacting to the child's cancer treatment and what might or might not be helpful for the sibling. So it's important to check with the parent to see if they would want the siblings classroom to have this, because it can be really helpful for those children to know what's going on as well, so the sibling doesn't have to field 1,000 questions about the cancer patient's return to school. Some other things that could be helpful here in terms of communication with the parents, using a two-way journal to send notes back and forth. It's important to schedule a follow-up and make sure that the plans, the accommodations and the plans are working. A case manager is very helpful, and we already discussed the classroom presentations. And now I'm going to pass it back to Mindy to present the second case.
Thank you so much. So this is Jaden. He's a 14-year-old boy who was diagnosed with acute myelogenous leukemia, a more aggressive form of pediatric cancer with a very intense treatment course. Jaden underwent a bone marrow transplant, which usually involves children being out of school for at least a year due to them becoming very immunocompromised from the process. Children are hospitalized for very long periods of time in isolation, so it can be very disruptive. And Jaden lives with his mother. Oops. So the health concerns of returning to school post bone marrow transplant, fatigue, not just from the medication, but just from being out of life in general for so long. Children can become tired quite quickly with all of the new routines coming back in. These children are also, Jaden is on ongoing immunosuppressive medication, which can have its own side effects. He may have symptoms of graft versus host disease, which comes with a lot of body image issues. It can involve weight gain, hair on children's bodies, acne, all sorts of things that can add to their self-consciousness. And there's a psychological sequelae from the lengthy hospitalizations and isolation from peers. There's a great many accommodations that we can consider for a child like Jaden. Adjustment to school attendance policy. It may be that this child isn't ready to go back to school full-time or may continue to have numerous hospital or clinic visits. A shortened school day, so he can go as much as he feels able to in the beginning. Rest periods throughout the day in a safe place, safe meaning free of exposure to kids with communicable diseases, such as kids going to the nurse's office with fever. A locker assignment close to his classroom and a longer passing period. A private bathroom with unlimited access. Often these children have a lot of GI issues from graft versus host disease. Permission to eat or drink throughout the day to keep his energy up. A modified PE schedule. Permission to wear a hat. Educational considerations. Extra copies of notes for lectures or perhaps a note taker. Shorter assignments to address concentration issues. A word bank or formula bank to address memory retrieval, recording lectures to address focus issues, a modified workload, again focusing on the quality of the work, not the quantity of the work. And as Kathy brought up in her presentation, it's so important that these children still have a measuring stick to measure themselves by, to feel like they are making progress. So it is still important these children get evaluated and get grades so that they can have a sense of mastery and accomplishment and get back into the groove of being in school. The use of a laptop or an iPad, ongoing assessment and close communication with the school team and perhaps with the hospital liaison. Emotional consideration. So Jaden is 14 years old. He may need to be encouraged to be more independent after having to be so dependent on adults for so long, while still making access to support easy. A respect for his privacy around dissemination of medical information and letting him really decide who gets what information. Identifying adult champions and encouraging peer support. Bringing in some friends that he identifies as safe people to both share information with and who can help him if he needs help with any medical or social issues. Maybe considering extra support from the school counselor or social worker. This child has been through a lot and may need some extra emotional support in the reintegration process. And really allowing Jaden to decide if he would like to have a classroom presentation and involving him in designing that curriculum. So now we're going to shift gears a little bit to what we fully expect that most children will survive their cancer and return to school and have successful educational paths and grow up and do wonderfully. But we do want to address the other side of the coin, and that's that small percentage of children who do relapse and move into palliative care. And at this point, the school still plays a vital role in the long-term well-being of the family and the immediate well-being of that child. The school can provide structure and a sense of well-being to a child who is dealing with a lot of change and a lot of uncertainty in their life. The school can really be a touchstone for them, and it can be a place where they can have a haven of respite from the daily medical grind. And schools can work with parents to set the tone in the school as being a safe place for the child to go to, a place where these children can touch base with friends and be in a normal environment. And it may look different for every child at what degree they are able to continue to participate in school. And some children may just want to come back for assemblies or the Valentine's Day party, or some children may want to continue to go to class as long as they can. And that's also something that shifts as the child's health status shifts. It's important that schools are flexible and supportive of the child, and especially of the sibling who is also experiencing something very traumatic and will go on being a member of the school community even after their brother or sister dies from their cancer. It's important to dispel rumors that might be going around. Children and teens do much better with accurate information. And it's important not just to support the student and their sibling, but also to support the school community and to offer guidance in how everyone's going to navigate this together. It's also very important to have an emergency plan. It is exceedingly rare that a child ever dies at school, but it is so reassuring to put in an ounce of prevention in the school and to have a written plan for what happens if that child does suddenly become acutely ill. If the family has a do not resuscitate plan, it's important that that also be at school so that school personnel can feel safe calling an ambulance and then handing over the plan and allowing the paramedics to take care of that child's medical needs, while also honoring the parents' wishes, to have all of the parents' contact information readily available as well, and to have people assigned in the school that have the prescribed roles should a crisis occur, so that people aren't feeling in crisis when they need to act. When a child does die, it can be extremely devastating for a school community. The family, I can't express strongly enough how important the school is in supporting a family who's lost a child. When a child dies, the family stops making new memories of that child. And the school community, all the children that knew that family, all of the staff that knew that family, or knew that child, when that family is ready, can provide just wonderful input and comfort to that family around ways in which they knew their child and cherished their child. And perhaps assigning that one person who was the caseworker to interact with that family and evaluate when is the right time for the school to reach out. Also having the school come in and really support the sibling during that time. the home environment is probably in a state of intense grief, and school may act as a respite for the sibling during that time to get a little bit of a reprieve and to participate in something normal for a few hours of the day. It's very important to support the students in the school community when a child dies. Giving accurate information, again, is extremely important. It's important for children to participate in memorial activity and for the school to come up with something in which children can honor their friend and move through the grief process. And you know, death is a part of life, and when children can be supported to move through it, it can really help them in their overall growth and understanding. This is a great time to utilize school counselors to help children who are having an especially hard time. I'd also like to emphasize it's very important to have a separate support mechanism for staff, and a place where staff who have known this child can grieve separately from students in an adult way. This is when the adults are able to process their grief and sort of get support from each other, they can much better support the children in their classroom. Okay, and we are now, these are some resources that are available to you, and Tanya, I'm going to turn it back over to you.
Thank you so much, both of you, for this really wonderful presentation and so much great advice about what to do in the classroom. This was really helpful. So what I'd like to do is ask anyone who has questions to feel free to type them into the question box, and we'll take a little bit of time now to go through any questions that you have. So I want to start with one question that we got during the webinar, which was, how do you deal with bullying, especially when a child first returns to a classroom and his or her appearance might be different? Things like hair loss and prosthesis, stuff like that, will make the child's appearance different. Do you have any suggestions for either proactively dealing with bullying or dealing with it after the child comes back to the classroom?
That's a great question. I think that we often, I think proactively trying to deal with it is the best by having a classroom presentation or a frank discussion with the children before the child comes back about what changes they might see and what is helpful and not helpful in responding to those changes. And not even to the point of bullying, but even you know, having kids react negatively to a wig or something can be hurtful to the child returning to school. So I think proactive addressing is the best possible. I've found it in my work that it often gets addressed by the children themselves, by the friends of the child with cancer returning are very quick to stick up for the child. And it can be helpful to even make that okay in your discussion, that if you see someone picky on your friend, that it's okay to tell them that's not okay. They can't say those things. So oftentimes I see it not get to the extent where it's bullying. It's usually isolated incidents that get quickly squashed by the child's friends. But if it becomes a problem, I think taking those children aside and intervening as you would in a bullying situation and with a child without cancer, you know, can help put a squash to it. But the proactive piece is the best if you can.
Thank you. So here's another question, which is, are germs an issue in the classroom? And especially with smaller kids, how do you teach them about being careful with germs around a child who's coming back who might be immune compromised?
Well, I would say this is, I would like to invite Dr. Amelon to also weigh in on this question. This is a great way as well to bring science into the classroom and to really build out a curriculum around good hand washing for kids. And that can be not just because of the cancer, but just cold and flu season, and kids learning how to be good hand washers at a young age benefits everyone. It's important to recognize that as nervous as we may feel around having a child who's immunocompromised in the classroom, the likelihood that the medical team would send a child back to school who was so fragile that and counts were so low that they could easily pick up something and become life-threatening is pretty low. But I would say that the ounce of prevention here really is teaching children to be very good hand washers.
And if I could jump in on that, I would absolutely agree with that. And the thing that I think might help the teachers to be a little bit more relaxed in the way they approach that, the doctors will have cleared the patient to go back to school before they show up. Catching something in the school setting can still have negative consequences for the patient, but it's more likely if they catch a cold or some other common virus in the school setting that it just means we're going to be worried that they have a more serious infection. They may have to go back into the hospital and have cultures drawn and be treated with antibiotics while we wait to see what develops. But it's very unlikely that that kind of infection is really going to have a big impact on their health. They may miss more school. They may not have to spend some time in the hospital, and those are obviously very worthwhile things to try to prevent. But the really serious infections are more likely to be something that either is in the patient's body already, a bacteria that escapes its usual anatomic location, or rare circumstances like chickenpox, which can be a serious thing but is much more easily identifiable in the classroom, and you can do other things to try to avoid that as well.
Thank you. Okay, we have a few more really great questions. One of them is from a listener whose son just finished treatment. He's 4 and he started pre-K a few weeks ago. And next year he'll be going back to the same school with other children. Would you recommend having a new presentation in the next year? How often do you think it's worth making sure that you get in front of kids in the classroom and remind them of these issues that kids will face?
Well, it seems like, there's a big leap between being 4 and being 5, and I'm not sure what kind of treatment this child is undergoing. But you may notice a very big difference from that child from age 4 to age 5, and that child may, because that is, 20% of that child's life, that child may have left some of these things behind and may really be functioning in terms of a classroom presentation, might really be functioning as just another member of the classroom, and you may want to evaluate when you've moved beyond some of the more intense portions of treatment, if that is something that needs to be highlighted in the classroom or not. From an educational perspective, as we discussed earlier, children who have a lot of treatment at a young age should be monitored very closely for educational issues, and it would probably be a very good idea to continue the team meeting aspect of evaluating if that child is having any special learning needs or if anything's evolving in that realm.
And the only other thing I would say is if the child still has some physical changes, if their hair hasn't grown back or perhaps their central line hasn't been taken out yet, sometimes they leave them in for a couple of months after treatment has ended. So anything that would make them stand out at all, it might be a good idea to even have a quick little discussion with class so they understand what's going on with this child.
Okay, great. Thank you. That's really helpful. Here's another question. What kind of accommodations do you suggest for university students? The listener writes that her son is a cancer survivor who had ALL, and he's 19, is in his second year of college, and now is feeling some long-term cognitive effects. Do you have any suggestions for follow-up care and working with a university setting?
That's a great question. I think that a lot of the accommodations that we mentioned would still be applicable, but they'll look different in a university setting, and you often have to go through different channels as well. It's important to find out if they have, a lot of universities will have like a center for learning, and perhaps even learning disabilities might be the name of it. that you can work with someone, that they can have an assessment done, determine the strengths and weaknesses of your son and what accommodations would be helpful. My guess is that some of the accommodations for attention and processing speed and executive functioning might be helpful. And so that might be things like getting tests in a quiet location outside of the typical classroom. It might be extended time for tests. And universities typically have very structured procedures for going through this, so it's helpful to get a contact within the office that handles student issues and student learning. And if you don't know who that is, it might be helpful to go to, typically when the student comes in, they get assigned some sort of like guidance person to help figure out the needs they have there. And so that person would be a good contact just to figure out what the name of the center is and how to get in for an assessment and get the formal accommodation plan in place.
I think another thing that's important in that context from the perspective of the family, the late effects are sometimes very different from the things that a child goes through in the early part of the disease while they're on treatment or very shortly thereafter, and they can vary widely depending upon what the primary disease was and what the treatment involved. And sometimes they don't show up until either time has passed and there are changes that occur in the brain or in the body, or when particular kinds of tasks are presented to the student that they maybe have not faced before, and so some kind of disability in abstract processing or three-dimensional visualization or different kinds of very specific skills may show up late. And one of the things that's important to remember from the family perspective, and that schools, if they see issues, can sort of remind the families about that as well, is that it's important to keep in touch with the primary treatment center even many years out after the treatment. A child who's diagnosed at the age of 3 or 4 with ALL may show up with learning disabilities when they're late in high school or even in college, and if they're not staying in touch with the people at their treatment center, then they may not know about issues that we may be able to tell them that they should expect and look for, and they also may not get access to some of the diagnostic testing that can be done to further sort of identify and characterize what issues they may be facing, and that can help a lot with planning for any kind of accommodations in the school setting.
Okay, here's another question. You gave us so many good suggestions about different accommodations to give to students at different times. When is a good time to ease children and teens back into functioning at school more independently? So maybe without having to leave class early or not needing someone else to carry their books. How do you work on that transition?
That's an excellent question. As the doctor of the group, I would say that I would always encourage that transition to occur as early as possible. That encouraging independence, encouraging the kids to feel competent again about being a kid and being a student helps to get them back on track sooner. The longer they are in the role of being sick and needing help and getting used to other people doing things for them, there's a little bit of a risk that they might become sort of accustomed to that. And so obviously you need to take into account their physical, emotional, and other capabilities, but I would always sort of come down on the side of encouraging them to be as independent and do as much for themselves as early as possible. That exercise of carrying their books around is going to be good for them. It's going to help them to regain their strength more quickly, help them to maintain muscle mass and bone density. So as long as they are physically capable of it, it's a good idea sooner rather than later.
And I would concur as the mental health component that these children need to start learning to be children, normal children again, and not identified as the kid with cancer. And you know, the sooner that we can shift their focus back into being a productive student in the classroom and shift it away from being a child who's sick and focusing on their physical symptoms and anxiety around infection and treatment and things like that is the sooner that they will be able to reintegrate back into just being normal kids. So that social, emotional shift is so important for these kids, getting them back in with their friends, getting them involved in the classroom, and getting them to sort of begin to see themselves as strong, capable, normal kids as soon as possible is of utmost importance. And we give you all of these accommodations because it's nice to have a menu of lots of things to consider, but we really want these kids to get back to just being normal, healthy kids as soon as possible.
Thank you. All right, so if there aren't any more questions, I just want to thank our wonderful panelists, all 4 of them, once again, and let you know that the recorded webinars will be up on CureSearch's site later this week, and we'll also send out an email with that link to anyone who attended today. So thank you so much for being here, and thank you for sharing this wonderful information, and I hope that you all found it helpful.